Hi, so welcome to the 2020 UCI Health Transplant and Nephrology Symposium. My name is Kristen Coe, and I am a nurse practitioner and clinical transplant coordinator at UCI Health. And I just like to start out by saying thank you for joining us today. I absolutely love transplant, and I'm really excited that we have this opportunity to come together and talk about a topic that is near and dear to my heart, which is waitlist management. I am one of the nurse practitioners and waitlist management coordinators for our center. So today I will be speaking about one of what I feel is one of the unsung heroes of transplant, which is waitlist management. Um, and I just want to start by saying that given our geographic and the specialty differences between all of those that may be in attendance, I just want to state that this presentation is primarily going to focus on renal transplantation, which is the majority of what we do at UCI. And then I'd also like to acknowledge that waitlist management is going to probably look very different at different transplant centers. So please just keep that in mind when we're discussing things. I'm going to be talking about what we do at UCI and what our experience has been. However, that may be very different from other centers that perhaps have shorter wait times or even centers with similar wait times. Um, Either way, I hope that you can take some key points away from this that are applicable to keeping patients transplant ready. All right, so let's get started. First, I just want to go over our objectives. So first, we'll just talk about the general transplant process, and then we'll review some national and local waitlist data so that we can have a better understanding as to why waitlists are what they are. Then I'd like to discuss some of the historical approaches to waitlist management that we've taken at UCI as ways of trying to manage our population to keep them transplant ready. And then I'm going to be going over our current system for waitlist management, and hopefully that will provide maybe some useful information for those of you that are trying to learn more about how to manage your own waitlist, or perhaps dialysis centers or nephrologists that may be listening to this may be able to glean a little bit more information about what we do at UCI for our mutual patients. All right, so here is a general overview of the transplant process that should look pretty familiar to most of us. So as we know, in the pre-transplant phase, patients are worked up and they're evaluated to determine if they're appropriate transplant candidates. And then once they're approved by selection committee, they get added to the wait list, and that's where they stay until they get that wonderful call, usually around 3 o'clock in the morning, letting them know that their name came up for an offer and it's ready. It's time to go to surgery. So after that, they go to surgery and then they enter their post-transplant life. So as we know, our patients are very excited to get those calls and they're eagerly waiting for them for a long time. However, the wait time for that call really varies across the nation, and the time keeps getting longer and longer. So before we delve into waitlist management, let's talk about why that is. Oh, and there's my heart because we love waitlist. Okay, so here's some national data about a transplant waitlist. This is from the OPTN, and so I put the links down below if you want to look at some waitlist data or other data from UNOS or the OPTN. So as you can see, in all, there are about 109,000 patients that are waiting for transplant, and over 92,000 of those are waiting for a kidney transplant. There are about 862 waiting for a pancreas and about 1,700 waiting for a kidney and a pancreas. Oops. And so this slide is just to show us that there is quite a discrepancy between the number of patients that are in need of transplant and the number of patients that actually receive a transplant. So we just discussed the numbers under the waitlisted column. So we said we had about 92,000 patients currently waiting for kidney transplant. But if you look at the 2019 transplant data, we as a nation did about 23,000 transplants. So though that is a phenomenal number, and it's awesome that we were able to help 23,000 patients, that is quite far off from the 92,000 number of people that actually need a kidney. So this just serves to show that there's a huge gap between the need and the resource, the organs that are actually available to meet that need. And the same is true, as you can see, for pancreas and simultaneous kidney pancreas transplant. So what does this mean? It means that transplant waitlists continue to grow as long as there is the unmet need and patients that will continue to need an organ and there not being enough organs available, the waitlists are going to continue to grow. So at our transplant center alone, we have over 700 patients on our list that are waiting for transplant. And some centers have larger lists, some have smaller lists, but our center alone is over 700. And where we are in Southern California, we are in what is considered the UNOS Region 5 area. We have a very large population in SoCal. People love the weather and there's a lot of fun stuff over here. So there are a lot of people and there is a lot of need for transplant. And so as a result, we have some of the longest wait times in the nation. And as you can see here, these are some of the approximate wait times for our OPO for a kidney. So you can see that someone that is blood type O will wait on average about 10 years, type A, 7 to 8, type B, 8 to 10, or if you're blood group AB, 5 to 6. And we do have a phenomenal OPO locally. They do a great job at doing their best to place organs. And we also have several very aggressive centers within our OPO. So even given all those factors, our patients are still waiting up to 10 years or sometimes even longer for a kidney. So as a result, this creates a really difficult situation for patients, for nephrologists, for dialysis centers, and for us as transplant centers, because what it means is that we have more people waiting for transplant than there are organs available. The wait lists continue to grow, wait times continue to increase over time, and our patients are not necessarily always getting better. They're oftentimes growing more ill and medically complex while they're waiting for a transplant. And then, as we also know, increased time on dialysis, though it's great in that it prolongs a person's life, it does contribute to increased morbidity and mortality. And so our patients tend to be sicker the longer that they're waiting for transplant. So on our team, we like to joke that the struggle is real, because it really is real. And our challenge is to identify ways to effectively and efficiently manage a large, a growing, and an increasing medically complex population that faces long wait times. And we have to make sure that they're ready for transplant at any time. So our challenge is to make sure that we are maintaining transplant readiness in order to transplant this complex population and get them off the wait list and onto their post-transplant life. So before we get into how we do that currently at UCI, I just wanted to talk about some historical approaches that we took so that you can have a better understanding and appreciation for where we are at today. So one of the approaches that we took in the past was called the top 50. Weightless management system. And what we did for this is we kind of had a focus on the top 50% of our waitlist. Now, please keep in mind that at that time our waitlist was much smaller. And basically what we were doing is we were doing HLA antibody testing for the top 50% of our waitlist population. Now, that was a lot of blood and a lot of testing, but that's what we did to try to stay ready in case they came up for offers. We also sent annual anniversary forms to dialysis centers or their nephrologist office to get some updates to see how they were doing. And then we would bring patients into clinic on an as-needed basis to do interdisciplinary reevaluations. The challenges that we found with this model is that we were testing a lot of patient blood, and not all those patients were being transplanted. In fact, a small percentage of those patients were being transplanted. And those of you that are familiar with HLA probably understand that that was very costly. And it is our duty to be good stewards of our resources. So that was something that we needed to look at. And another challenge with this model is that it didn't include a formal process for comprehensive team reevaluation. We would bring patients in as needed, but we didn't really have a systematic way for the entire team to reevaluate the patient. And then an ongoing issue was that as our waitlist continued to grow, our resources didn't necessarily continue to keep up with the pace of the growing list. And so, for example, things like clinic space became a challenge. So then we got our heads together and said, well, how can we make this better? And from that came the top 20 waitlist management system model. And in this, instead of looking at the top 50% of patients, we started focusing in on the top 20% of patients on the waitlist. And what we did was we evaluated the top 20% in clinic every year, and then we would order reevaluation testing. So things like their cardiac testing, their abdominal imaging, all those things that we wanted to make sure that they were, our candidates were staying ready for transplant. We continued with the annual anniversary forms and would do additional consults or diagnostic testing as needed. And the challenge with this model is that what we were seeing was that when we were doing the testing after the patients left the clinic, there were a lot of issues that would come up that would warrant additional follow-up visits, additional follow-up calls, more testing. And we didn't have the staffing that we needed or the resources to manage the volume of the work that was being generated, and kind of the issues that came up from this more comprehensive reevaluation process. And so we had to take a step back and say, okay, well, this was better than what we did in the past, but it's not quite working the way that we need it to work for it to be sustainable. And so our team took a step back and looked at our processes again. And what we came to was our current system, which is called the tiered waitlist management system. And I'll just take a pause here just to remind everyone that this is what UCI has developed and implemented. We have found that it has been very successful for our center and our specific population and our geographic area where we are at. So please just keep in mind that this is for UCI, and other centers may have similar or very different systems. So the basic premise of this system is that we categorize our patients according to certain factors into different tiers. So we have tier 1, 2, 3, and 4. And our patients fall into each tier according to different factors such as blood group, how long they've been waiting for transplant, which is their UNOS qualified time, what kind of organ they need. Do they need a kidney alone, or maybe they're a pancreas or simultaneous pancreas and kidney transplant? We would look at their antibody level or their CPRA, their age, and what their hepatitis C status is. And what we do is we categorize our patients and then we manage them according to whichever tier they're in. So patients that are higher up on the tier system get more intensive management. Patients that are lower on the tier system don't get quite as much management, but still enough management that we can maintain transplant readiness in case they do get organ offers sooner than expected. So for example, a zero mismatch kidney or a directed donation. We want to stay ready for those opportunities. So this is a visual. This is actually from the first page of our lengthy waitlist tiered management system document. And what this is just showing is how we categorize each tier, and we'll dive into these different tiers together over the next few slides. So the tier ones, who are these recipients, these are what we estimate to be about the top 10% of our wait list. These are the patients that we are hoping are going to be coming up for organ offers in the near future. So in this tier, we have the top 10% of each blood group, A, B, and O. And then for the AB blood group, we have patients that have more than 3 years of qualified wait time. We also have our simultaneous pancreas and kidney transplant candidates in here because their their wait times are a bit shorter than kidney. A lone transplant. We also have patients that are highly sensitized who have antibody levels or a CPRA level above 90% in this category. And that has to do with how the current allocation system works and scoring. And then we also have patients that are consented for a hepatitis C transplant if they fall into this category because their wait times may be substantially shorter as well. So what do we do for this tier? What do we do for the people that we're hoping are going to get transplant offers in the near future? Well, we do annual chart reviews to assess where they're at, see what testing's been done before and what they may need to update. And then we order reevaluation testing per protocol before they come to clinic. So me and my waitlist team will go through and order labs, imaging, cardiovascular testing, and age-appropriate cancer screenings based on the current patient's situation and their medical history. And we get that all done before they come into clinic. And then we bring them into clinic where they see that they have their medical reevaluation. And then they also see our interdisciplinary team, the social worker, our dietitian, and our pharmacist. They reevaluate them according to their individual protocols as well. We continue with annual anniversary forms to be sent out to dialysis centers or the nephrologist's office to get updates from the people that see them and know them the best. And then we also order additional consults and testing as clinically indicated. The next tier down is the tier 2s. So this is the population that maybe we don't think are quite at the cusp of getting organ offers and getting a transplant, but we think that they're getting close and we want to stay ready because sometimes they do come to them sooner than we expect. So this is approximately the top 11 to 20% of the A, B, and O blood groups. And then we also have blood group AB that has qualified wait time less than 3 years. And then we also have sensitized patients. They're still sensitized, but a little bit less than the tier 1s. So these are people that may have CPRA values between 50 and 89%. The reevaluation for this tier looks similar to the tier 1, but we just don't do quite as much. So we still conduct annual chart reviews. We update reevaluation testing for protocols and consultation with our physician team. However, we do not do a clinic visit for this population unless it's indicated. We do continue with our team reevaluations with the interdisciplinary care team. We continue with annual anniversary forms, and we also will continue to order additional consults or testing as clinically indicated. Tier 3s, this is our next tier, and this is for our older population. So this is for transplant candidates that are 70 years of age or older that don't qualify for Tier 1 status. So for example, if we have a 70-year-old that maybe has about 5 years of dialysis time, they have a CPRA of 0%, they would likely fall into the Tier 3 category. However, if we had another 70-year-old that had 9 years of wait time, they would likely fall into the Tier 1 category and be managed appropriately. So this is for our older adults that don't fall into the higher category. And the reason that we created a separate tier for our older population is that, as we know, with age, our patients become increasingly complex, especially while they're on dialysis, and have a lot of common comorbidities like diabetes, hypertension, coronary artery disease. So we just wanted to carve out a tier so that we can pay a little bit closer attention to our older population. And what we do for this tier is we conduct annual chart reviews. The physician team and myself will review the charts together and then determine if a patient should be seen in clinic that year for reevaluation. And if so, we reevaluate them and determine if they remain a viable candidate. And if so, we will go on to order additional testing as indicated, such as abdominal imaging and cardiovascular testing, so that we can maintain transplant readiness. We continue with our interdisciplinary reassessment. We continue with annual anniversary forms, and of course, we'll order additional consults and testing as indicated. Oh, excuse me. Okay, Tier 4. So this is the last tier. And this is for all of our other transplant candidates that don't meet criteria for Tier 1, 2, or 3. This is the tier that we anticipate is probably going to have longer wait times than the other tiers. So for this tier, our management isn't quite as intensive. However, we do like to keep our patients active on the list so that they can still be open to opportunities that may arise, such as a zero mismatch kidney or a directed donation. So for this tier, we conduct annual chart reviews. We update reevaluation testing, which mostly consists of cardiovascular testing. We don't bring them into clinic unless there's a reason to. And our interdisciplinary care team continues reevaluation per their protocols, and we continue with annual anniversary forms and any other clinically indicated reevaluation items. Now, I mentioned for each tier that we order cardiovascular testing, and so as part of our tier management system, we have worked very closely with our cardiologists to develop some protocols for who is going to get tested when. And so we order, for example, EKG, echo, stress test, and then plus or minus cardiac catheterization. We order this all according to where they fall in the tiers. Are they a Tier 1 or are they a Tier 4? A Tier 1, we're probably going to want to have a little bit more recent testing than perhaps a Tier 4. So we look at their tier status, we review their medical history for key factors that would be important to consider when evaluating their cardiac status. So things like diabetes, how long have they had diabetes? Are they someone that just got recently diagnosed, or have they maybe had it for 30 years? We look at for history of coronary artery disease, peripheral vascular disease, history of stroke, and a lot of other factors. We also look at their age. Usually our recipients that are over 50 years old are going to have testing a little bit more frequently. And then we also like to consider whether they're going to be candidates for a kidney transplant or perhaps they're going to be candidates for kidney pancreas transplant, in which case they may we may consider being a little bit more aggressive about a cardiac catheterization for their pre-op evaluation. And in all of this, we work very closely and appreciate our community cardiologists as well as our UCI cardiologists to help us evaluate our patients and to optimize them prior to surgery. And I would like just to point out, especially for the dialysis centers and nephrologists that we partner with, that if you hear that we are referring one of our mutual patients to a UCI cardiologist and they do have an outside cardiologist, please understand that we are not trying to steal them away from their cardiologist. We want them to continue with them and continue under their care. But for some patients that have certain conditions or we deem as higher risk for cardiovascular complications during transplant or after transplant, we sometimes like to send them to the UCI cardiologist that we partner closely with for a pre-transplant evaluation, but they do not take the place of the patient's regular cardiologist. And so through this evaluation, we then come to classify our patients as having either high, moderate, mild, or standard cardiovascular risk for transplant surgery. And then this is just to speak a little bit more to the psychosocial assessment of patients that we do during reevaluation. And so we have wonderful social workers that regularly assess the stability of social support for our recipients and the environment that they're in. They help us to understand patients' preferred languages, their ability of support for after transplant, transportation, how are they going to get to and from the hospital for all of the follow-up visits and labs, or in the event of an emergency, and what's their living situation like. They also evaluate a patient's knowledge of their disease, their ability to, their financial ability for paying for medications and ensuring successful transplant outcomes, as well as their compliance. They also look at areas and behaviors that may be problematic for transplant, such as alcohol use, smoking, or other substance use. And then they also evaluate for psychiatric concerns such as anxiety, depression, or other psychiatric issues. And then similar to the cardiovascular stratification, these patients get stratified as having either high, moderate, or standard psychosocial transplant risk. We also have a wonderful transplant pharmacist that assesses our patients regularly for medication compliance, their reading and writing ability, because that is very important when it comes to post-transplant life and their ability to be successful with post-transplant medication adherence. She also assesses for drug interactions. For example, there are seizure medications that can commonly interact with our post-transplant medications. So we like to know about those things before we go to transplant. And then also herbal agents, because sometimes patients start taking things and maybe no one really knows about it, or maybe we do know about it, but we want to consider that in the context of the post-transplant medication regimen. And then these patients also get classified as high, moderate, or standard risk for surgery. And then nutritional risk, our dietitian is wonderful at connecting with patients and partnering with our dialysis dietitians to assess A1C levels, to see how well our diabetics are controlling their sugars. She looks at BMI, adherence to their renal diets, and she also takes into consideration if the recipients have any special dietary needs or special feeding modalities. And then she also definitely takes in consideration things like a bariatric surgery, if they had difficulties in the past after procedures, malnutrition episodes, or eating disorders.
and their cholesterol. She also is very good at encouraging exercise and assessing a patient's activity level. And then she also classifies patients as high, moderate, or standard nutrition risk for transplant. And so in addition to the interdisciplinary team reevaluation, we also reevaluate patients' HLA profile. So for every patient that's active on the wait list, we require a serum update every 90 days. And so those of you that are attending from local dialysis centers probably know that our lab sends little kits to you, and there's a little red top in there that we ask to be sent back every 90 days. What we do with that blood is we send it to our HLA lab for processing, and then that blood also gets sent to the regional lab so that if a patient comes up for an organ offer, we have blood on file to test the compatibility against the specific donor and do a cross match. And then antibody testing, we do now for the top 10% of each blood group. They get tested every 90 days. And then we do additional antibody testing as clinically indicated for things like sensitizing events, such as a blood transfusion or recent infection, so that we can have a current HLA antibody profile at the time of transplant in order to ensure adequate matching. And so we talked about a lot of stuff, a lot of stuff, and how we manage our wait list, but how do we actually do this? How does it all come together? So especially for those coordinators that may be listening, trying to glean ideas for how to perhaps improve processes for management of your wait list, what we do is we try to break our wait list up into more manageable pieces. And the way that we do that is we generate monthly reports that have a certain subset of our waitlist population. And we do, for that month, we work on that patient for doing this reevaluation. So for example, this coming week, I'll be printing the October report, and then those are all the patients that I will be working on and my teammates will be working on for reevaluation. And then we also, so one of the other things that we do that we have seen as an improvement is that we bring patients into clinic for reevaluation and also as clinically indicated, with the goal of trying to have most of the testing done prior to the clinic visit if possible, and if it's appropriate in that situation, so that at the time of the clinic visit we can address the medical and interdisciplinary needs of that patient to try to address everything during the visit and minimize all the follow-up that we were seeing with historical models. And so a question that I'm sure a lot of you have and that we had was, does this new system actually work? And from our team's perspective, we thought, well, yeah, it actually does really seem to be working, but we don't like to go by feelings. We like to go by facts and data. So our team got together and we looked back and said, you know, is this working? Are our patients ready for transplant? Now, that was something that was difficult to assess and come up with metrics for. But what we identified was to say, well, were they comprehensively reevaluated within the 18 months prior to their surgery? So this process officially went live in April 2017. And so we looked at our transplants prior to that time and then after implementation. And what we found was that prior to the tier system, for all transplants at UCI, about 54% or 55% were reevaluated within the 18 months prior to transplant. And then when you removed outliers, kind of those transplants that may come out of the blue, such as a zero mismatch or directed donation, we actually found that there was a good portion of patients that were reevaluated, about 89%, that were reevaluated within 18 months prior to transplant. However, there was room for improvement. And so after the implementation of this tier system, we found that with the outliers, so all transplants that we did, we had reevaluated 84.8% of patients within 18 months prior to transplant. And then when you removed outliers such as the zero mismatch, directed donations, or patients that just got put on the list and didn't have time for reevaluation, we found that we had actually reevaluated 96.4% of patients within 18 months prior to transplant, which is awesome. So this poster down here is actually something that our team presented at ATC to talk about our system and the work that we've been doing on Waitlist at UCI. So that's how we manage all of our active patients, but I'm sure a lot of you know that we also have an inactive population, which consists of patients that aren't ready for transplant. And that can be for a variety of reasons. That can be due to medical issues, it could be due to psychosocial issues, it could be due to financial issues, such as maybe they lost their insurance or they switched their insurance and aren't fully covered. So whatever the reason is, the goal for our status 7 patients is to get them back to active status. And so we identify what the issue was that made them inactive and then work towards resolving that issue and any other issues that maybe need to be addressed prior to transplant. And if we find that a patient isn't a transplant candidate, then our goal is to get them removed from the list. And for our management of the status 7 patients, how do we go about getting them back to active? It's really an individualized approach. We do chart reviews, we request outside records, we'll often call dialysis centers or referring nephrologists to really work on whatever the issue is. We also bring these patients into clinic to have interdisciplinary reevaluation with our team, and then we'll order testing and consults as needed to get them back to active status. And then once they're back on active status, we follow the tier management system that we just discussed. So what are we going to do moving forward? For now, we find that the tier management system has actually been very effective and it's working really well. However, we are continuously reevaluating and adjusting our processes and workflows to adapt for sustainability purposes with a growing wait list and our patient population. We have identified some opportunities to improve waitlist education, so we're really excited to start working on some additional waitlist education endeavors this upcoming year. And then there are going to be some changes in the allocation system coming downstream. So we're going to have to look at what we're doing and adapt to those changes so that we can continue to be successful in ensuring transplant readiness for our population. So with that, I would like to thank you all so much for your time, for hopefully paying attention, and for everything that you do for our patients and the transplant community. We so appreciate you, and we welcome your feedback and any questions that you may have. Thank you all, and please stay safe and healthy. Take care.